In recent years, asymptomatic TB, or subclinical TB, has become a topical subject of discussion in the TB community, as efforts are mounted to detect TB actively and earlier in the course of illness. Greetings. My name is Dennis Falzon, and on behalf of the Global Program on Tuberculosis and Lung Health of the World Health Organization, I am pleased to present on this subject. This presentation will cover the implications of asymptomatic TB, abbreviated as ATB, on the work of TB and other health programs in countries. It will also briefly discuss the new WHO definitions for ATB and research needs to support policy development. The first global strategies on tuberculosis from the early 1990s emphasized the need to find people with TB using sputum microscopy in people presenting to the health services with suggestive symptoms, particularly prolonged coughing. The NTB strategy for the period 2016 to 2035 emphasizes prominently the need for TB screening and active TB case finding as means to bring incidence to levels which would end the global threat of TB. TB screening is also included in the framework for TB elimination of 2014. ATB is a condition that is only detectable through screening and TB disease prevalence surveys. As these activities expanded, there was increased realization about the frequent occurrence of ATB among people with treatable disease, which averaged to around 50% of TB cases detected in disease prevalence surveys. It has been known since many decades that not all people with TB report or admit to symptoms, or even show physical signs of disease. Historically, WHO TB definitions did not distinguish between symptomatic and asymptomatic disease. This makes it difficult to have a common understanding of asymptomatic TB. A common definition can help surveillance and guide what diagnostics to use. Defining asymptomatic TB will also signal its importance in programmatic management. Even though a definition of ATB has not been in widespread use, many TB programs do report that they notify and treat people with ATB. In recent years, attempts have been made to define ATB primarily for research purposes. In early 2024, the International Consensus for Early TB, or ICE-TB group, published a definition and research agenda for ATB. Individuals with ATB were described as those who are without, not aware of, or do not report any symptoms during a symptom screen or medical history, and have no physical signs that would be recognized as indicative of tuberculosis upon clinical examination. WHO convened experts in October 2024 to discuss the relevance of current knowledge on ATB to programmatic action and decide if a programmatic definition would be feasible and useful. The participants of the consultation included national TB program staff, academic groups, technical agencies, civil society, and funding partners. The participants to the WHO consultation concluded that a definition of ATB would be helpful for health programs at this point in time. The definition would be structured alongside the standing WHO surveillance definitions for TB disease released in early 2024, shown on this slide. There would be subsets of ATB that are bacteriologically confirmed using rapid test, culture, or smear microscopy, or bacteriologically unconfirmed, which is currently termed clinically diagnosed. ATB was thus defined as a person with TB disease who did not report symptoms suggestive of TB during screening. It is important to note that ATB is defined at the time of initial screening, and the status should not be changed if the person develops symptoms subsequently in the course of illness. Before classifying a person as having ATB, it also needs to be determined that the person has disease and not just TB infection. This is made on the basis of bacteriology, imaging, or histopathology. Two subsets of the ATB definition, categorized as bacteriologic confirmed and unconfirmed, are shown on this slide, alongside the corresponding existing TB surveillance definition. Thus, people with TB could be stratified by both symptoms and bacteriological status. This slide highlights some of the key characteristics of the TB patients in each of these four subdivisions. Symptomatic TB is the most common form of TB that is notified, mostly through passive case finding, and bacteriological tests are most often used to confirm disease, although not all people who are treated for TB will necessarily have a positive test. Detection of bacteriologically unconfirmed ATB relies upon patient history and imaging and histopathology findings, and may require follow-up testing to diagnose. The increased recognition of asymptomatic TB has a number of implications for current WHO guidance on TB. The definitions of ATB will be integrated into the TB Surveillance Guide, and the data elements required to classify a notification as symptomatic or ATB defined for individual level reporting. In the area of infection control, there will need to be consideration of ATB in respiratory separation practices within the limits of what is possible. This also raises the importance of early detection and treatment of ATB. Rule-out algorithms that are commonly based on symptoms will now need to assess the potential for people with ATB among those who are considered eligible for TPT. The infectious potential of ATB will also influence whether TPT recommendations should be extended to contacts of an ATB index case. A screening algorithm which only refers for clinical evaluation those individuals who are symptomatic will now need to be evaluated in light of the risk of missing ATB. Revised estimates of the contribution to transmission of ATB cases in the community will have a bearing on the TB prevalence threshold used to recommend community-wide screening. Insofar as diagnostics are concerned, ATB opens questions about the algorithms to use to detect it in children and adults, and about how to diagnose bacteriologically unconfirmed ATB in particular. One key question will be the role of tests of TB infection in the diagnosis of ATB. Guidance on the treatment of ATB would need to wait until trial data become available. In the meantime, ATB is treated as for symptomatic disease. As part of the consultation, meeting participants also ranked research needs by order of importance. The biggest current needs were felt to be in the space of diagnosis, followed by studies of transmission, treatment, and operationalization. Topmost among the research needs were the impact of ATB detection on TB epidemiology, TB screening strategies, diagnostic reference standards, and optimal treatment approaches. The main findings from the consultation, including the definitions, were released a few weeks after the meeting as part of the Global TB Report of 2024. A more detailed account of the discussions during the consultation can be found in the full report shown here. Finally, I would like to thank the many contributors to these slides, including WHO colleagues, participants of the WHO consultation on ATB, and the Bill and Melinda Gates Foundation and other funding partners. Thank you for listening.